Now I'm just repeating the information, but from New England Journal of Medicine in 2017, they had a major paper directed towards all clinicians, psychiatrists, non-psychiatrists, on how to taper off a benzodiazepine. And they are probably a little bit faster than I like it. But again, the point being, slow is better. You can do it at 50% a week, all the way down to 10 to 25% every 2 weeks, or even longer. Just be slow, reassure the patient, and move in the right direction. And this is actually a pretty good way to think about it. What you may want to do is you can take off the first half of the drug pretty rapidly, but that's the quick part. The slow part is this one, which is the final 50% and the final 25%. Just take your time. Just take your time. Hurrying almost always is a bad thing when it comes to benzodiazepine withdrawal. Okay? There are some situations you should not consider a withdrawal or taper off at all. What if the patient is quite depressed? This would be the wrong time to consider a benzodiazepine withdrawal or taper off. What if the patient is in a mixed manic episode and the reason for the mixed mania has nothing to do with benzodiazepines? That'd be the wrong time to pull it off. What if the patient's going through a particularly bad crisis? That'd be the wrong time to pull a person off benzos. You can obviously educate them that we will do it in a month, 2 weeks, whatever. But don't just do it because it struck your fancy, because today you decided that's how it's going to be. Be very thoughtful. Psychotherapeutic interventions, we have 3 separate goals here. Facilitate the withdrawal itself, but we also want to make sure they don't go back to it. And the best way to do that is to make sure that they have other tools to help them deal with anxiety or insomnia or whatever the case might be. Of course, treating the underlying disorder is ideal. Very quickly, let's focus on psychoeducation and CBT. Got very good information from the VA paper I talked about. It's such a good paper, you may actually want to do a journal club with it. It offers great direct advice on how to talk to patients, what language to use, how to use motivational interviewing, how to negotiate, how to create a joint agreement, and then how to coach patients. I know we are in the world of psychiatry, so we tend to see ourselves as quote-unquote psychiatrists. But here we may have to adopt the coaching model. A good mental health clinician has skills that come from all different specialties, including motivational, where coaching, not telling patient what to do, but coaching them is very important. And just to prove how valuable it can be, this is a McGill University experience. All they did is they used psychoeducational materials. They didn't even talk to the patient. They just gave them paperwork. These are people who were using benzodiazepines chronically. And they say, are you taking these medications? You may or may not be at this risk. If you do decide to decrease the medication, here's one way to do it. They actually gave them the step-by-step tapering off program. And you're going, oh, this could never work. Yeah, patients are all drug addicts and all they want is the medicine refilled and blah, blah, blah. Right? Isn't that the thought that goes to your mind? That probably is true for a percentage of patients, maybe 10, maybe 15, maybe 20, but the vast majority, that was not the case. Check this out. 86% of patients completed the 6-month follow-up. They started the conversation with the clinicians. They actually went to the clinician and said, I didn't know there was a problem with this drug. I just read about it. They also, on their own, 1 out of 4, on their own, just said, I can find a way to stop it. 5% at 6 months of the control group. In other words, yeah, the psychoeducation is actually quite powerful. And dose reduction, which by the way is a terrific thing from the perspective of harm reduction, happened in 11% more of patients. Don't assume if a patient's older, they can't do it. Don't assume if they're male or female, they can't do it. Don't assume that they've been on it for 6 months or 60 years. Therefore, only the 6-month one will succeed. Don't assume that. The McGill study showed us, it was published in JAMA. It showed that actually, in fact, it did work. It did work for a substantial number of patients. And by the way, we can go beyond that, right? You and I can do more than just hand them some paperwork. Our success rates might be even better than that. So CBT is a great model to use when you're thinking about augmenting the benzodiazepines effect, but also making sure that you use CBT to help the patient successfully taper off their benzodiazepine. More information to remind us that we never operate with one tool. Not psychiatry, we don't. We use combinations. We use psychoeducation, we use CBT, we use patient empowerment, we use medications. We're like a surgeon. If you told a surgeon the only tool you can have is a scalpel, nothing else, they would say, I can't do a good surgery. Psychiatry can't do good intervention if all it chooses to do is prescribe drugs. We have to do more. All right, now that time is running short, I will remind you again that CBT, when it's added on to your taper schedule, look at the odds ratio at 3 months, 5.3, 500% greater risk of success if, besides just telling them how to cut back on their benzodiazepine, you add tools from the world of CBT, from motivational interviewing. If you add that, it can be very effective short term, but even at 12 months. In fact, at 12 months, the odds ratio of success went up by 7.6, 760%. Pretty big deal, right? Okay, so let's do this. I will not cover more data, but pretty much the data actually points in the same direction. When you offer them a taper schedule with psychotherapy, with tools, with empowerment, these patients do well, both in the short run and the long run. And I'm showing you multiple studies just because I want you to make up your mind how to do it rather than just feel that there's only one way to do it. So CBT is extremely powerful, even in this pharmacologically challenging situation. So in conclusion, my illustration comes back. See that clinician balancing it, but balancing it very well. If you have this man standing on that central thing with two things, it rarely falls off. So I have this strong belief, if we do things right, we can do benzodiazepines the right way. Sometimes we may go a little bit left, a little bit right, but we can actually do it. Please remember, treatment guidelines, not one treatment guideline in the world has said never use benzodiazepines. They say judicious use is appropriate. Number two, many patients use them without issue long term. It is also true that fear-mongering is not the right way to go. It'll backfire. It'll harm our patients. It'll harm us. But we also have to be quite aware that caution is necessary. We have gone through periods of over-exuberance with benzos, but we also went through an overly negative view of benzodiazepines. And I would urge the specialty to come somewhere in the middle and for the right patient, take the right approach. Does that sound reasonable to you? Okay, so 3 top practical takeaways are: before using benzodiazepines, assess. Be thoughtful. Don't be automatically rejecting or automatically embracing of it. And if you can, consider obtaining informed consent, and please consider a signed contract. Number 2, there are worries. We are not going to deny that. There's risk of dependence, there's risk of addiction, the risk of overdoses, so minimizing that, and we have lots of tools to do that. If you do decide to taper, do it slow and don't do it just as a pharmacologic intervention. Try and combine elements from CBT and from motivational interviewing. The data is very persuasive. That leads to the highest chance of success. All right? And please remember the 4th point, not to be ignored. Some patients truly do need and deserve long-term maintenance therapy on benzodiazepines. Their needs must be respected and long-term therapy continued, of course, with all the safety parameters that we have talked about. With that, I thank you so much for hearing me out.